Hello everyone, I am myself Dr. Ramya Raj Gubba. I am the general medicine educator. So in this session, I will be discussing the neurology questions of the UPSC. So in which these questions were asked previously in the UPSC exams, and these questions are completely of the neurology chapter. So starting with the first question, which of the following statement is correct regarding the lower motor neuron type of lesion? Fasciculation is absent, deep tendon reflexes are increased, spasticity is present, plantar reflex shows the flexor response. So lower motor neuron lesion, fasciculations are present. They are like pathognomic of the 𝐿MN palsy or 𝐿MN lesion. The deep tendon reflexes, they are completely absent in case of the lower motor neuron type of paralysis. And the tone, if you observe, the tone is not increased. So you don't have spasticity. What is that you will have is the flaccidity, right? And then what is the true statement? The plantar reflex shows the flexor response. That is a true statement in case of the lower motor neuron type of lesion. So if you see the differences between the upper motor neuron and lower motor neuron lesion, in case of upper motor neuron lesion, what are the muscles which are affected? So it is the group of muscles, right? It is the group of muscles which are affected in case of upper motor neuron lesion, and it is never the individual muscles in case of upper motor neuron paralysis. Whereas in lower motor neuron paralysis, the individual muscles, right? The individual muscles may be involved in case of the lower motor neuron type of paralysis. And if you take the muscle atrophy, the atrophy in case of upper motor neuron lesion, we call this as disuse atrophy. Whereas lower motor neuron type of paralysis, the atrophy, it is marked atrophy, or the atrophy that occurs in bulk. Okay, so almost 70% of the total bulk of the muscle, it gets paralyzed. Okay, it gets atrophied. And tone, if you see in case of upper motor neuron lesion, there is spasticity, right? So there is increase in the tone in case of upper motor neuron lesion, whereas in lower motor neuron lesion, you will have the flaccidity, where there is decrease in the tone of the muscle. And what about the plantar reflex? The plantar reflex in case of upper motor neuron lesion, it is upgoing plantars. And this upgoing plantars, we call this as the Babinski sign. Right? We call this as Babinski sign. Whereas in lower motor neuron lesion, the plantar reflex, it will be the normal response, that is the flexor response. And what about fasciculations? Fasciculations, they are absent in case of the upper motor neuron lesion, and the fasciculations, they are present in the lower motor neuron type of paralysis. And what about the nerve conduction studies? The nerve conduction studies in case of the upper motor neuron lesion, the nerve conduction studies, they are normal. Whereas in case of lower motor neuron type of paralysis, there will be abnormal nerve conduction studies, or there will be decremental response in the nerve conduction studies. And what about EMG, that is electromyography? Electromyography, there is no denervation potentials. Right? So there is no denervation potential in the electromyography. Whereas you take lower motor neuron lesion. In case of lower motor neuron lesion, there will be, right, there will be abnormal electromyography. Okay, the response, right, there will be abnormal electromyography response. So that is about the EMG. So these are the differences between the upper motor neuron lesion and as well as the lower motor neuron type of paralysis. Now you need to know an important point about the fasciculations. So what exactly are the fasciculations? Fasciculations, they are either visible or palpable twitch, right? Visible or the palpable twitch within a single muscle fiber. Right, within the single muscle fiber. Okay, that is what is called the fasciculations. And this particular fasciculation, it is due to spontaneous discharge. Right, so this is due to spontaneous discharge of one motor neuron. And if you take the pathology for the development of the fasciculation, the pathology is within the anterior horn cell, and it is the sign of lower motor neuron lesion. Right, it is a sign of the lower motor neuron lesion. And what are the various diseases that will cause the fasciculations? Fasciculations, they are predominantly observed in case of the motor neuron disease. Observed in case of spinomuscular atrophy, the fasciculations are very common. Then followed by that, poliomyelitis, the fasciculations are very common. Then followed by that, syringomyelia. Right, so it's a condition where there is formation of syringomyelia. So it's a condition where there is dilatation within the central canal of the spinal cord. Then even in case of diabetic amyotrophy, there will be fasciculations. And very important poisoning, that is the organophosphorus poisoning, right, there will be presence of the fasciculations. Then followed by that, in case of hypoxia, like you will have the fasciculations. Then in cases of the hyperglycemia, right, there will be presence of the fasciculations. So these are the various diseases that will be causing the fasciculations, right? And one more important part of the discussion here between upper motor neuron and lower motor neuron lesion is about the plantar reflex. See, plantar reflex, it is a superficial reflex. Right, it is a superficial polysynaptic reflex, right? And this is a sensitive and reliable method. Right, it is the sensitive and reliable method for evaluating the integrity of the motor pathways to the lower limb. So we will be able to make out the integrity of motor pathways to the lower limb. And how is it being elicited? See, the plantar reflex, with the help of a blunt object, from the lateral aspect of the foot, the blunt stimulus is given to the medial aspect of the toe. What is the normal response? The normal response is the complete flexion of all the fingers. Then what is the abnormal response? Or in case of the upper motor neuron lesion, you will have what is called Babinski sign, which is called extensor plantar reflex. What is this extensor plantar reflex? Extensor plantar reflex is upon giving this blunt stimulus over the plantar aspect of the foot, there will be extension of the great toe. Right, there will be extension of the great toe. And what about the other toes? There will be fanning of the other toes. Right, there will be fanning of the other toes. So this is what is your extensor plantar reflex, which is seen in case of upper motor neuron lesion. Now, this elicitation of the plantar reflex is not just only by giving the blunt stimulus over the plantar aspect of the foot. There are various ways by which the plantar reflex can be elicited. So this is like the routine way. Okay, the other one is like we have the open hem method. What is this open hem method? Like when we rub over the shin of the tibia, if there is upper motor neuron lesion, there will be extensor plantar reflex. That is open hem method. And the next one is the Chedok. Right, what is this Chedok method? You need to apply the blunt stimulus over the dorsal aspect of the foot from lateral to the medial. If there is upper motor neuron lesion, there will be extensor plantar response. And next is the Gordon's method. What is this Gordon's method is, you need to squeeze the calf muscle, and when there is upper motor neuron lesion, there will be extensor plantar response. So 3 methods. three other methods: Oppenheim, then Chaddock, and then the Gordon method. So these are the various methods by which the plantar reflex can be elicited. So what are the various causes of the extensor plantar reflex? First and foremost, that is the upper motor neuron lesion, that is in pyramidal tract lesions. Right, in pyramidal tract lesions there will be extensor plantar reflex. Then the presence of extensor plantar reflex, it is normal in children up to the age of 1 year, because until 1 year the myelin sheath is not being formed around the pyramidal tract. So until then the plantar reflex, whenever you elicit, there will be extensor plantar reflex. Next, in cases of deep sleep, right, then in patients with coma, patients under the effect of general anesthesia, next postictal stage of the epilepsy, right, then in conditions like electroconvulsive therapy, ECT, right? So ECT stands for the electroconvulsive therapy, right, which is given for the psychiatric patients. Then in patients with hypoglycemia, there can be extensor plantar reflex. Then in conditions like alcohol intoxication, right, in conditions like alcohol intoxication. So these are the various causes of the Babinski sign or extensor plantar reflex. Then this extensor plantar reflex or Babinski sign, there are various types. True Babinski sign. True Babinski sign means what? Like it is a scenario where there is like fully developed extensor plantar response. Right, fully developed extensor plantar response. Then what is minimal Babinski sign? It is characterized by just only the contraction of the hamstring muscles. Right, there is just only contraction of right, so there is just only contraction of the hamstring muscles, and as well as right, and as well as the tensor fascia lata, right, and this contraction of the hamstring muscles and as well as the tensor fascia lata, this can be detected by palpation of thigh. Right, so this can be detected by the palpation of the thigh. So upon eliciting the plantar response, eliciting the plantar reflex, there will be just only contraction of the hamstring muscles and tensor fascia lata, and that can be detected by the palpation of the thigh, right? Then followed by that, spontaneous Babinski sign. Spontaneous Babinski sign, it is encountered in patients with extensive pyramidal tract lesions. Right, so in cases of extensive pyramidal tract lesions, right, there will be spontaneous Babinski sign where there will be passive flexion of the hip and passive flexion of the knee, or there can be passive extension of the knee, right, passive extension of the knee. Okay, so that may produce a positive Babinski sign in adults. So this is called spontaneous Babinski sign. It is encountered in scenarios like when there is extensive pyramidal tract lesions, right? Then coming to the crossed extensor response or bilateral Babinski sign. So this crossed extensor response or bilateral Babinski sign, it may be encountered in cases of bilateral cerebral or the spinal cord disease. Right, so bilateral cerebral or spinal cord disease, there will be crossed extensor response or bilateral Babinski sign. Okay, here unilateral foot stimulation, right? Unilateral foot stimulation that will elicit a bilateral response, right? That will elicit the bilateral response in such cases. Then what is 𝗠𝐞𝐵𝐵𝐚𝐴𝑠𝑘𝑦 reflex? This is characterized by slow prolonged contraction of, right, slow prolonged contraction of toe extensors. Okay, so this is what is your 𝗠𝐞𝐵𝐵𝐚𝐴𝑠𝑘𝑦 reflex. So this 𝗠𝐞𝐵𝐵𝐴𝑠𝑘𝑦 reflex, where do you observe? You observe that in patients with combined frontal lobe and as well as the pyramidal tract lesions, right? So in cases of combined frontal lobe and pyramidal tract lesion, you have the presence of 𝗠𝐞𝐵𝐵𝐚𝐴𝑠𝑘𝑦 reflex. So these are the various types of the 𝐵EVINSky, right? So one is your true 𝐵EVINSky, like fully developed extensor plantar response. Next is minimal 𝐵EVINSky sign, which is caused by contraction of the hamstring muscles and tensor fasciae lata, which can be detected by palpation of the thigh. And second one is spontaneous 𝐵EVINSky sign. This is encountered in patients with extensive pyramidal tract lesion, right? And where there is passive flexion of the hip, knee, or passive extension of the knee. Then crossed extensor response or bilateral 𝐵EVINSky sign. This is encountered in cases with bilateral cerebral or spinal cord disease, where unilateral foot stimulation will elicit bilateral response in such cases. And next one is the 𝗠𝐞𝐵𝐵𝐚𝐴𝑠𝑘𝑦 reflex. This is characterized by slow prolonged contraction of the toe extensors, and this is encountered in patients with combined frontal lobe and as well as the pyramidal tract lesion, right? So coming on to the next question. So that question was completely upon the differences between upper motor neuron and lower motor neuron lesion. Next, which of the following is the single strongest risk factor for dementia? Increasing age, alcoholism, positive family history, systemic illnesses. So in fact, all of these are the risk factors for the dementia, but out of all these, it is increasing age which is the strongest risk factor for dementia. And one of the common reasons for dementia in increasing age is the Alzheimer's disease. Now, let me discuss about the Alzheimer's in detail. So first of all, you need to know the definition of the dementia, where there is decline in the intellectual function of the individual, right? So where there is decline in the intellectual function, and the decline in intellectual function that is severe enough to compromise the social or occupational functioning. And this particular dementia, it is distinct from delirium and psychiatric disease. What is delirium? Delirium, it is an acute confusional state, right? So acute confusional state. So this is what is your delirium, and this delirium, it occurs in response to an identifiable trigger. What will be the trigger? Either a drug or alcohol intoxication or alcohol withdrawal. That is the one which will be causing delirium. And this dementias, we have cortical dementia and subcortical dementia. And example of the cortical is the Alzheimer's disease, right? Alzheimer's. Then Pick's disease, which is nothing but the frontotemporal dementia, and dementia of 𝗠𝐾𝐢𝐻 disease. These are all the cortical dementias. Subcortical dementias, you see that in case of Parkinson's disease, then Huntington's disease, next in patients with multiple sclerosis, and even progressive supranuclear palsy. Okay, so these are the causes for subcortical dementia. Mixed dementias, where you have both cortical and subcortical features will be there, and you see that in case of vascular dementia, right? Vascular dementia, where you have a multi-infarct dementia, right? Then, and you need to know what is the predominant site which is affected in case of the Alzheimer's disease. In Alzheimer's disease, it is the temporoparietal cortex, right? So it is the temporoparietal cortex predominantly affected in case of the Alzheimer's disease. Okay, frontal lobe may also be involved, but predominantly it is the temporoparietal cortex. Whereas in case of Pyqs disease, which is called frontotemporal dementia, so the part of the cortex which is affected is frontotemporal cortex. Right, frontotemporal cortex. Then if you take this Alzheimer's, most cases they are sporadic. Right, most of these cases they are sporadic. Only 5% of them they are inherited as autosomal dominant type of inheritance. And what is the mutations in the Alzheimer's is, you have mutation in the amyloid precursor protein which is present on chromosome number 21, and you have the mutation in presenilin 1 and presenilin 2. Presenilin 1, right, presenilin 1, it is present on chromosome 14, whereas presenilin 2, this is present on chromosome 1. So these are the mutations in case of the Alzheimer's. What are the risk factors? One of the very important risk factor is the increasing age of the individual. So the risk factors for the development of Alzheimer's, one of the very important risk factor is the increasing age of the individual. And apart from that, the other factors include the female gender, then low socio-economic status or low educational attainment, next family history of dementia, and there are numerous environmental factors, and these numerous environmental factors include aluminium toxicity, next mercury, certain viruses and prions. So these are the various risk factors for the development of the Alzheimer's, and there are certain drugs or there are certain factors which will decrease the risk of development of the Alzheimer's. And what are those? That includes the postmenopausal estrogen use will reduce the risk of Alzheimer's, and then the usage of the NSAIDs, non-steroidal anti-inflammatory drugs use will reduce the risk of the Alzheimer's. And if you see the topographic distribution of the neurofibrillary tangles, but before that, if you see the pathology, what is the important structures which gets atrophied is the cerebral cortex, or so these individuals, they will have widespread or there will be diffuse cerebral atrophy, and particularly the cortex and as well as the hippocampus. And if you see the histopathological accumulations, so in the histopathological accumulations you have two important things. One is beta amyloid and the other one is hyperphosphorylated tau protein. Okay, so you have the presence of the beta amyloid and as well as the hyperphosphorylated tau proteins. So these two are the very important histopathological accumulations in the Alzheimer's disease. And you take this beta amyloid. Beta amyloid, like we have two forms. One is the neuritic plaque and the other one is amyloid angiopathy, right? Neuritic plaque, and the other one is amyloid angiopathy. And this hyperphosphorylated tau proteins, they are nothing but the neurofibrillary tangles. And you take this beta amyloid. The beta amyloid, the important point is they are extracellular, right? They are extracellular. Whereas the neurofibrillary tangles, these are the intracellular distributions. Okay. And which part of the cortex, which part of the brain gets affected commonly in the topographic distribution? That is the hippocampus, right? So entorhinal cortex, that is hippocampus, that is most vulnerable. Hippocampus is like most vulnerable. The other areas like limbic system and temporal cortical areas and association areas of the neocortex, these are the other areas. But the most common will be the hippocampus. And what are the biochemical abnormalities in Alzheimer's disease? The biochemical abnormalities is there are certain neurotransmitters which are decreased and there are certain neurotransmitters which are affected. So the primary biochemical abnormality is decrease in the acetylcholine. This is the like primary biochemical abnormality. And the other biochemical abnormalities that gets affected is there will be decrease in the norepinephrine, there will be decrease in serotonin, and there will be decrease in somatostatin. Right, there will be decrease in somatostatin. So these are the biochemical abnormalities of the Alzheimer's disease. And the clinical features, what is the very important, that is the memory loss. So memory loss, that is the important clinical feature. And apart from the memory loss, the other important abnormality that you will have is, right, word finding difficulty. Then there will be also visuospatial dysfunction, executive dysfunction, and there will be also apathy. Then what is the treatment? The non-pharmacological treatment options that we have is, the individual is advised to do the aerobic exercise. And this aerobic exercise, 45 minutes should be done every day. And apart from that, frequent mental stimulation, right? Frequent mental stimulation, even this will reduce the rate of the functional decline. And whereas the pharmacological treatment includes the acetylcholine levels are reduced. So you need to give acetylcholine esterase inhibitors, which will increase the acetylcholine levels. And the examples, they include donepezil, then galantamine, and next rivastigmine, right? And next rivastigmine. So these are the pharmacological drugs. And these donepezil, galantamine, rivastigmine, they are given in case of mild to moderate form of the Alzheimer's disease, whereas you take in case of the severe form of Alzheimer's, right? In case of the severe form of the Alzheimer's, the drug that you need to give is memantine, right? So memantine should be given in case of the severe form of Alzheimer's. So this is about in toto related to the Alzheimer's. And we have a new molecule which is directed against mainly the aggregated beta amyloid. What is that particular drug? It is a monoclonal antibody. It's an antibody which is directed against the aggregated beta amyloid. And what is that? The example of that particular drug is aducanumab, right? So aducanumab, this is the drug that is directed against the aggregated beta amyloid. So this is about the dementia, and very important form of dementia that we have discussed is the Alzheimer's. Okay, next question. Visual hallucination is the characteristic of which type of dementia? Diffuse Lewy body dementia, frontotemporal dementia, Alzheimer's dementia, and then the vascular dementia. Okay, so visual hallucination, it is the characteristic of diffuse Lewy body dementia. And this diffuse Lewy body dementia, what is the inclusion body which is accumulated? See, there are various types of proteins which are being aggregated. Depending upon the type of the protein which is being aggregated, we have the tauopathies where there is accumulation of the tau protein, then alpha-synuclein protein where there is synucleopathies, then amyloid beta protein where it is amyloidopathies. Now, what are the conditions where you have like tauopathies or the tau protein which is accumulated, right? So that is the Pyqs disease. So in Pyqs disease, it is the tau protein. Then in other conditions like the progressive supranuclear palsy and then corticobasal degeneration, these are the conditions where you have accumulation of tau proteins or tauopathies. Then alpha-synuclein protein, which is synucleopathy. So this is your diffuse, right? So diffuse Lewy body disease and as well as multiple system atrophy. So multiple system atrophy, the example is the Scheidegger syndrome. Okay, And yeah, so these are the alpha synuclein protein or the synucleopathies. Then amyloid beta protein or amyloidopathies, you see that in case of the Alzheimer's disease, right? So Alzheimer's disease and as well as cerebral amyloid angiopathy, right? Cerebral amyloid angiopathy. So these are the protein aggregates or protein aggregate inclusions resulting in the neurodegenerative disorders. Okay, so out of which the visual hallucination is seen in which condition? That is diffuse Lewy body dementia, right? Now coming on to the next question. So this question is related to the topic of the headache. A 47-year-old mother of 2 children has bilateral headache that worsens with emotional stress. Pain is less severe in early part of the day but becomes more severe in the evening. There is tenderness over the skull vault. Both children are not doing well in the school. What is the most likely diagnosis in the 37-year-old mother? The options are cluster headache, tension headache, trigeminal neuralgia and migraine. So this is like the classical presentation of the tension headache, right? So 2 children, right, not doing well in the school and the pain is worsening upon emotional stress. Early part of the day the individual is fine, but it is more severe in the evening. So as the time progresses, the stress increases within the individual and thereby in the later part of the evening, the tension headache will be more severe. Now, so if you see the classification of the various types of headache, and I'll be discussing in detail about the migraine, cluster headache, tension headache, and as well as the paroxysmal hemicrania and SUNCT. So these I'll be discussing in detail. So the most common type of the headache is, that is the tension headache, right? So the most common type of headache, this will be the tension headache. And the most common type of secondary headache, right? So this is due to infections, whereas the tension headache, it is the primary headache, whereas the infection, it corresponds to the secondary headache. And the most common cause of headache in females, right? So that will be tension headache. And most common cause of headache in males, even that is also the tension headache. Okay, and next to this, migraine is like the next most common cause for the headache in males, then followed by that cluster headache, whereas even in females also migraine, it is the second most common cause. And what is the most common cause for the frontal headache? It is again the tension headache, that is the most common cause of the frontal headache. Now let me discuss in detail about the migraine, tension headache and as well as the cluster headache. So if you take this migraine, so how is this migraine being defined as? Migraine, it is the second most common, right? It is the second most common cause of primary headache. What is the most common cause of primary headache? That is tension headache. Whereas the second most common cause is the migraine, and this is usually episodic in nature. And this headache of the migraine, it is associated with certain features such as sensitivity to light, sensitivity to sound, sensitivity to movement. Okay, and this particular migraine, it is pulsating type of headache, right? It is pulsating type of headache and it is around 1 day in duration on an average. So the total is around 4 to 72 hours, but on average the duration of the headache is around 1 day, and it is mostly unilateral. And this headache, it is associated with nausea and it is disabling in character, right? Disabling in character, which is of throbbing in type. So out of these 5 features, at least 4 should be there. So 4 out of 5, they should be present for the diagnosis of migraine. And when do you call status migrainosus? If the duration of the headache, if it is more than 72 hours, then we call it as the status migrainosus. And there are various theories of migraine. Initially, the vascular theory was one which used to be followed, but in the recent times, we have CGRP theory. And this CGRP theory, it is calcitonin gene related peptide theory. So this is a new theory, right? Calcitonin gene related peptide that will act on vascular terminals, right? So this will be acting on vascular terminals of the fifth nerve, and it will irritate the nociceptive fibers of the fifth nerve, and that will cause cortical spreading depression that will result in the development of migraine. And this migraine, it is mainly of two types. One is migraine with aura and the other one is without aura. So migraine with aura, right? So this is the classical migraine. Whereas migraine without aura, this will be the common migraine. And if you take this aura, like we have the various forms of the aura, right? In case of the classical migraine, there is various forms of the aura. The various forms of aura, it includes like the uniform flashes of white or silver light, and that we call it as, right, that we call it as photopsia, where you have uniform flashes of white or silver light. And the other one is scintillating scotoma, right? So scintillating scotoma, it is enlarging blind spot with shimmering edges. That is what is called the scintillating scotoma. Then you have dazzling zigzag lines, and the dazzling zigzag lines, right? So this is what is called as 𝗕𝐞𝐝opsia. 𝗕𝐞𝐝opsia, it is a formation of dazzling zigzag lines where you have like fortification spectra or the 𝗕𝐞𝐝opsia, right? And there can be focal neurological symptoms other than aura. The focal neurological symptoms can be in the form of paresthesia. It can be in the form of weakness of arms or leg. There can be mild aphasia. So then you have ophthalmoplegic migraine. Ophthalmoplegic migraine is that where there is transient, along with headache, there is transient 3-4-6 cranial nerve palsy. That is what is your ophthalmoplegic migraine. Then we have retinal migraine. Retinal migraine is that migraine with involvement of retinal circulation. Right, migraine with involvement of the retinal circulation, and due to the involvement of the retinal circulation, there will be monoocular blindness. Right, there will be monoocular blindness. Then we have hemiplegic migraine. Hemiplegic migraine, it is an autosomal dominant trait, and this hemiplegic migraine is the one which is characterized by a unilateral paralysis. That is the hemiplegic migraine. And next is basilar migraine. Basilar migraine is that migraine along with prominent brainstem symptoms, right? Migraine along with prominent brainstem symptoms, that will be the basilar migraine. And how will you assess the severity of the migraine? By a scoring system called MIDAS scoring system. What is MIDAS scoring system? That is Migraine Disability Assessment Test or Migraine Disability Assessment. Okay, that is what is called MIDAS. In that MIDAS, you have a various list of questionnaire, and this MIDAS, it is given grading. So that is 1, 2, 3 and 4. What is this 1? Where there is little or no disability, the score is around 0 to 5. Whereas in 2 is mild disability, and 3 is the score being around 11 to 20, moderate disability, and 4 is like severe disability where the score is like more than 21. And in case of mild to moderate form of the migraine where the score is like less than 20, the first line approach will be COX-1 inhibitors, right? COX-1 inhibitors. The example is indomethacin. But the problem with this indomethacin is it can cause the gastritis. Okay, so some patients, they are not able to tolerate this indomethacin. In them, you need to give COX-2 inhibitors. And examples of these COX-2 inhibitors will be 𝗉𝐶𝐸, right? That will be 𝗉𝐶𝐸. And COX-3 will be like paracetamol 1 gram with caffeine should be given. Whereas in case of the severe form of migraine, where the score is like more than 21, in this scenario, the drug of choice will be the triptans, right? Where we give sumatriptan, and this sumatriptan, it can be given as mouth dissolving tablets, nasal sprays, right? So these are the various, and they can also be given as subcutaneous injectors, or the sumatriptan can also be given as the transdermal patches. Okay, Next, for status migrainosus, what is the drug of choice? For status migrainosus, the drug of choice will be, for status migrainosus, the drug of choice will be prochlorperazine, right? So that will be the drug of choice. Okay. Then you need to know the drugs that are given as prophylaxis for migraine. Prophylaxis for migraine that we give is some antihypertensives. What are the antihypertensives? Like we give beta blockers, then we give calcium channel blockers, and then the ACE inhibitors. So examples of beta blockers will be like metoprolol, propranolol, and examples of this calcium channel blockers are mainly the verapamil, and then the ACE inhibitors or angiotensin receptor blockers. So these are the antihypertensives that can be given as the prophylaxis. Then followed by that, antidepressants. Examples of these antidepressants that includes the tricyclic antidepressants like amitriptyline, nortriptyline, doxepin, right? And then followed by that, the another important group of antidepressants are selective norepinephrine reuptake inhibitors. And this selective norepinephrine reuptake inhibitors, the example is venlafaxine. And the other group of drugs are the anticonvulsant. The anticonvulsants that includes valproic acid, then we have topiramate, and then gabapentin, right? And then gabapentin. So these are the three groups of drugs which are given as the prophylaxis. Now in the recent times we have the CGRP antagonists which are also given as the antagonists. So they are given for preventive treatment. Even the CGRP antagonists, they are given for prophylaxis. And what are the drugs that we give for the prophylaxis? We give this through the either intravenous route or oral route or the nasal route. But what are the examples of these CGRP antagonists? The examples of these CGRP antagonists that include erinumab, right? That includes erinumab, okay? And the other one is eptinezumab. The other one is eptinezumab. So these are like intravenous route. The oral formulation that we give is that includes atogepant. So atogepant, this is the oral formulation. Then we have nasal formulation, and example of the nasal formulation is JVG-pant. This is the nasal formulation. So this is the CGRP antagonist which can be also given as the prophylaxis, and these are the new molecules, right? So this is about the discussion related to migraine. The other important form of headache is the cluster headache. So cluster headache is that where the number of episodes, they appear in the cluster pattern. They appear in the cluster pattern. Okay. So here the individual will be completely headache free, right? Will be headache free between the episodes, right? Between the episodes, and the individual will be like headache free for almost months to years, right? For almost months to years. And these episodes, once they appear, the episodes will appear for nearly around 6 to 12 months. So they'll be like completely headache free for months to years, and followed by that for another 6 to 12 weeks or 6 to 12 months. Okay. So for around 6 to 12 weeks, they'll be having continuous episodes. The age of the individual is around 20 to 50 years. And male to female ratio, if you observe, it is more common in males than compared to females. The characteristic feature of this cluster headache is, it is also usually unilateral, and it is periorbital localization of the pain. And here the eyes, they become completely red, and there will be discharge from the eyes, and the pain will be very severe, right? So very intense pain that you observe in case of the cluster headache. And the duration of the headache, it is less than 3 hours. And what are the associated features? The associated features of the cluster headache, that includes the nostril, it becomes blocked, so blocked nostril. There can be also discharge from the nose, that is rhinorrhea, right? And there can be also redness of the conjunctiva, and there will be even lacrimation from the eye. and even there can be meiosis. And how do you treat in case of acute cluster headache? In acute cluster headache, you need to give high flow oxygen, and that high flow oxygen should be given at a rate of 12 liters per minute, and this is considered to be the first line treatment. And the other drugs that can be given is the sumatriptan or gabapentin or pregabalin can be given. So it is mainly the high flow oxygen at a rate of 12 liters per minute, that is the first line treatment. Okay, so that is the one which can reduce that acute attack. And what are the drugs that are given for prophylaxis in case of the cluster headache? That includes verapamil. This is one important drug, and the other one is great occipital nerve block. Right, great occipital nerve block. So these are like the drugs which are given in case of the prophylaxis for the cluster headache. Then followed by that, the tension headache. So tension headache, this is like the most common cause of primary headache, and it is usually bilateral. Whereas you take in case of migraine and cluster headache, they are like unilateral, but this is like usually bilateral. And if you take the character of the headache, it is dull and aching. And where exactly will be, or the patient will be complaining of the fullness within the head, or the patient will be complaining of tightness of the head, okay, or the patient will be complaining of pressure over the head, right? And the headache is not very severe, it is just only dull and aching. This will be there even throughout the day. It's like described as dull, boring type of headache. And the exact site of the headache, bilateral, frontal, right, bilateral, frontal and temporal. And the age group, like very commonly observed in the middle-aged women, more common than males. And you have a stressors for this, right? There will be a trigger like anxiety, fatigue, a depression. And the treatment is the individual has to take rest, or a simple paracetamol will also reduce the headache of the tension headache. So this is about the description of the tension headache. So this is in detail related to the migraine, cluster headache, and as well as the tension headache. So that was the question on the topic of the headache. So if you see the differences between the cluster headache and another important form of headache called as 𝐮𝐬. What exactly is the 𝐮𝐬? It is short lasting unilateral neuralgiform headache attack with conjunctival injection and as well as the lacrimation, and then paroxysmal hemicrania. So if you see the type of headache or the character of the headache, in case of the cluster headache, it is the stabbing type of headache, whereas in case of 𝐮𝐬, it is burning or stabbing type of headache, whereas in case of paroxysmal hemicrania, it is throbbing, right, or the character of the headache which will be described is a dull, boring type of headache like what we describe in case of the tension headache. And where exactly will be the site of headache? In case of cluster headache, it will be in the orbital area, whereas in 𝐮𝐬, it is periorbital area, whereas in case of paroxysmal hemicrania, it is within the orbit and as well as within the temple. So these are the sites of headache in case of paroxysmal hemicrania. Now what exactly is the attack frequency? In case of the cluster headache, the attack frequency, it can be 1 episode per day, or even it can be 8 episodes per day. So multiple episodes can be there in case of the cluster headache, whereas in 𝐮𝐬, the number of episodes, they are nearly around 3 to 200 episodes per day, right? And for diagnosis, how many are required? For diagnosis, a minimum number of more than or equal to 20 episodes per day are required for the diagnosis of 𝐮𝐬. Whereas in case of paroxysmal hemicrania, the number of episodes will be like 1 to 40 number of episodes per day, right? So per day, it can be up to 40 episodes, right? And for the diagnosis, minimum there should be 5 episodes per day for the diagnosis. What is the duration of attack? The duration of attack in case of the cluster headache, it can be as short as 15 minutes or it can be as long as 180 minutes, which is nothing but almost like 3 hours. Whereas in case of 𝐶, it will be like very short duration. It will be like 5 to 240 seconds. And in case of paroxysmal hemicrania, the duration of headache can be 2 minutes and it can be as long as 30 minutes as well. And what about the autonomic features? Autonomic features, they are present in case of the cluster headache, and they are also present in 𝐶 and as well as the paroxysmal hemicrania. And what about the active treatment? In case of the cluster headache, one is the oxygen inhalation, that is high flow oxygen, and along with that the drug will be sumatriptan, right? The drug will be sumatriptan. Whereas in case of 𝐶, the drug of choice will be lidocaine, and this particular lidocaine, what is the route of administration? It is the intravenous route of administration. And in case of paroxysmal hemicrania, there is no effective treatment in case of the paroxysmal hemicrania. Only prophylactic treatment can be given, and that prophylactic treatment is the NSAID, that is indomethacin is given, right? Indomethacin is given. And what is the prophylactic treatment for the cluster headache? For the cluster headache, the short-term prevention. So you can give verapamil, that is the calcium channel blocker. And another important molecule is lithium, the drug which is used in the treatment of bipolar disorders, can be given in cluster headache. Whereas in 𝐶, what is the prophylactic treatment? The prophylactic treatment will be lamotrigine or like topiramate and then gabapentin. So these are the drugs that are given in case of 𝐶. So this is about the various types of headache, like where we have discussed about the migraine, then we have discussed about the cluster headache, then we have discussed about tension headache, then we have given a comparison of 𝐶, paroxysmal hemicrania and as well as the cluster headache. So this was the question related to the topic of the headache. Next question. Which of the following are the causes of the polyneuropathy? HIV, alcohol, phenytoin, rifampicin. Select the correct answer using the code given below. So the one which are responsible for the development of polyneuropathy is HIV, alcohol and as well as phenytoin, but not the rifampicin. So the correct answer is 1, 2 and as well as 3. Now you need to know the signs and symptoms of the peripheral neuropathy. The peripheral nerves which can get affected is, there can be large fiber involvement, small fiber involvement, motor involvement and as well as the autonomic involvement. So what will be the features of the large fiber involvement? The features of the large fiber involvement include numbness, tingling, pins and needles and as well as the poor balance. So these are the features of the large fiber involvement. Then what are the features of, what will be the signs of the large fiber involvement? That will be decreased vibration, decreased joint position sense and as well as decreased reflexes. That will be the features of, that will be the signs of the large fiber involvement. And what will be the features of the small fiber involvement? The features of the small fiber involvement will be usually burning or shock-like sensation, or it can be stabbing, pricking, shooting sensation or lancinating sensation. The signs of the small fiber involvement include decreased pinprick and decreased temperature sensation. And if you take the motor involvement, the features of the motor involvement, motor fiber involvement will be in the form of cramps, weak grip, foot drop and the twitching. And what will be the signs of the motor fiber involvement? That includes reduced strength and as well as reduced reflexes. And the next important fibers are the autonomic fibers. Due to autonomic fibers, there will be decreased or increased sweating, right? There is a hyperhidrosis or anhidrosis, dry eyes and as well as dry mouth, erectile dysfunction, gastroparesis or diarrhea, faintness or the lightheadedness. So these will be the autonomic features that you will see in case of whenever there is autonomic fiber involvement. And signs will be like orthostasis, unequal pupil size and resting tachycardia. So these will be the features of the large fiber, small fiber and motor and as well as the autonomic fiber involvement. Now at the same time you need to know what are the etiologies that will be causing sensory neuropathy, what are the etiologies causing pure motor neuropathy and what are the etiologies that are causing the autonomic neuropathy. So this is another important thing that you need to know. So in case of the sensory, again we have the small fiber involvement, large fiber involvement and as well as mixed. So in case of the small fiber involvement, that is hereditary sensory neuropathies, lepromatous leprosy, diabetic neuropathy, amyloidosis, Tanger's disease, Fabry's, dysautonomia, then HIV and antiretroviral therapy. So these are the etiologies which will cause small fiber neuropathy. Large fiber neuropathy, that includes Sjögren's, vitamin B12 neuropathy, cisplatin neuropathy, pyridoxine toxicity, and then Friedreich's ataxia. Then what are the etiologies that will be causing both small and as well as the large fibers? That includes carcinomatous sensory neuropathy, hereditary sensory neuropathies, diabetic sensory neuropathy, Wecker intoxication, xanthomatous neuropathy of primary biliary cirrhosis. So these are the etiologies that are like mixed. Then what are the etiologies that will be causing motor neuropathies? That includes Guillain-Barré syndrome, hereditary sensory motor neuropathies, acute intermittent porphyria, diabetic neuropathy. This diabetic neuropathy, it is like actually mixed. It can cause both sensory and as well as the motor. But diphtheric neuropathy, it is purely motor. Then lead brachial neuritis, then diabetic lumbosacral plexus neuropathy or diabetic amyotrophy. So these are the conditions where you have motor neuropathy. Whereas autonomic neuropathies etiologies include, we have acute and as well as the chronic causes. The acute causes are acute pan dysautonomic neuropathy, botulism, porphyria, Guillain-Barré syndrome, amiodarone and vincristine. And chronic causes are like amyloid, diabetes, Sjögren's, then Chagas, paraneoplastic diseases. So these are the various etiologies that will be causing like the autonomic neuropathy, both acute and chronic. So this is the question on the topic of the peripheral neuropathy, and among the options which has been given to you, the one which will be causing the polyneuropathy is HIV, alcohol and as well as the phenytoin, right? Next question. So the next question is on the topic of the stroke. Consider the following statements regarding the intracerebral hemorrhage. It accounts for 10% of all the strokes. Most common site or the hypertensive intracerebral hemorrhage is the cerebral stroke. Use of cocaine and methamphetamine is a frequent cause of stroke in young age. Fourth option, hypertensive intracranial hemorrhage usually results from spontaneous rupture of small penetrating artery deep in the brain. So which of the statements are correct? So now intracerebral hemorrhage, this will account for 10% of all the strokes, that is correct. And most common site of the hypertensive intracerebral hemorrhage is the cerebral cortex, that is a wrong statement. And use of cocaine and methamphetamine is a frequent cause of stroke in young age, that is also a wrong statement. And hypertensive intracranial hemorrhage usually results from spontaneous rupture of small penetrating artery deep in the brain, that is also a correct statement. So the correct statement here are 1 and as well as 4. Now, so if you see the definition of the stroke, TIA, and the detailed discussion of the stroke. So this definition of the stroke is, it is the scenario where there is sudden onset neurological deficit. Right, sudden onset neurological deficit, and this is of the vascular basis. And this sudden onset neurological deficit, that will be lasting longer than 24 hours. Right, that will be lasting longer than 24 hours. Then what is transient ischemic attack? It is a scenario where there is neurological deficit that will be lasting for less than 24 hours. Then we have RIND, that is reversible ischemic neurological deficit. Reversible ischemic neurological deficit is that the neurological deficit will be there for 24 to 72 hours. That is what is called as RIND, reversible ischemic neurological deficit, which is also considered as the minor stroke. Now, this repeated TIA, TIA is what, where there is neurological deficit for less than 24 hours. This repeated TIA can progress to the development of stroke. Now, what is that scoring system which will tell you that repeated TIA goes into a state of stroke? That will be ABCD2 scoring system. Now, in this ABCD2 scoring system, A stands for, right, A stands for the age of the individual. If the age of the individual is like more than or equal to 60 years, give a score of 1. And B is blood pressure, where systolic blood pressure is like more than 140 millimeters of mercury and diastolic blood pressure more than 90 millimeters of mercury. If it is there, give a score of 1. And clinical symptomatology, if there is unilateral weakness, give a score of 2. And if there is speech disturbance without weakness, give a score of 1. And then the duration of the transient ischemic attack. So if the duration of the transient ischemic attack, if it is like more than 60 minutes, give a score of 2. And if the duration of the transient ischemic attack, if it is in between 10 to 59 minutes, then give a score of 1. And if the individual is diabetic, give a score of 1. So if we calculate the total score, it comes around 7. And please remember, more is the ABCD2 scoring system, more is the chance that the transient ischemic attack will progress, right? That transient ischemic attack will progress to the development of the stroke, right? So this is about the importance of the ABCD2 scoring system. And you need to know this terminology called watershed infarcts. Watershed infarcts, these are also known as border zone infarcts. Right, so these are also known as the border zone infarcts, which develop from relative hypoperfusion in the most distal arterial territories. And this watershed infarct, where there is relative hypoperfusion, this can produce bilateral symptoms. Okay, then we have a disease called Binswanger's disease. Binswanger's disease, like, it is a scenario where there is multifocal small infarcts. Right, so multifocal small infarcts or ischemia. So this multifocal small infarcts or ischemia, this may result in slowly progressive neurological disorder. Right, so this may result in slowly progressive neurological disorder causing multi-infarct dementia and subcortical arteriosclerotic encephalopathy. That is what is your Binswanger disease. And overall, what is the most common cause of the stroke? It is ischemia. And within the ischemia, the stroke can be either, it might be because of thrombus formation, or it might be because of the embolus in the cerebral vasculature. So within the ischemia, the most common cause of the ischemia will be embolism, right? It will be embolism rather than thrombosis, right? And the other cause of the stroke will be the hemorrhagic stroke. But between the ischemic stroke and hemorrhagic stroke, 85% it will be ischemic stroke, and only 15% etiologies are like the hemorrhagic stroke. So the vascular disorders that will be causing the ischemic stroke, that includes atherosclerosis, and the next important etiology is vasculitis, then systemic lupus erythematosus, and then syphilis. So these are the vascular disorders that will be causing, or that can cause, the ischemic stroke. And the cardiac disorders that can cause the ischemic stroke is the rheumatic heart disease causing atrial fibrillation, presence of the thrombus, and that too mural thrombus can shower an emboli into the cerebral circulation. Next, mitral valve prolapse syndrome, infective endocarditis. So these are the cardiac disorders that can cause the ischemic stroke. Whereas the hematological disorders that can cause the ischemic stroke, that includes, very important, is polycythemia, which can increase the viscosity of the blood causing the stasis and thrombus formation. And similarly, thrombocytosis, where there is increase in the platelet count. Then leukocytosis, like increase in the WBC count. And then sickle cell disease. So these are, right, sickle cell disease. So these are the hematological disorders that will be causing the ischemic stroke. Then followed by that, like if you take the hemorrhagic stroke, what are the various etiologies that will be causing hemorrhagic stroke? So like the intracerebral hemorrhage, it could be secondary to hypertension, or subarachnoid hemorrhage, this could be secondary to rupture of the, so this could be due to head trauma or rupture of the berry aneurysms, right? So these are the etiologies that will be causing subarachnoid hemorrhage. And the other causes for the hemorrhagic stroke will be the epidural hemorrhage and as well as the subdural hemorrhage that will be causing the head trauma. And the most common cause of the stroke will be the embolic stroke. Now, where exactly the source of the embolus is from? The source of the embolus, it is from the severe left ventricular failure secondary to the ST elevation MI. Right, secondary to the ST elevation MI, that will be causing severe left ventricular failure, where there will be stasis of the blood, and that stasis will cause the thrombus formation, and that thrombus can shower an emboli. So that will be the most common cause of the embolic stroke, that is the ST elevation MI causing severe left ventricular failure. Now then followed by that, you need to know that ischemic stroke, like okay, before that, the most common cause of the intracerebral hemorrhage, that will be the hypertension, right? If you see the most common cause of the hemorrhagic stroke, we have the intracerebral hemorrhage, then we have subarachnoid hemorrhage, then epidural hemorrhage, right? And then the extradural or subdural hemorrhage. Okay, now out of all these, the most common cause of the ischemic stroke will be the intracerebral hemorrhage, right? And within the intracerebral hemorrhage, like the most common cause of the intracerebral hemorrhage will be the hypertension. And what is the most common site of the hypertensive hemorrhage? The most common site of the hypertensive hemorrhage will be within the putamen. So putamen is the most common site for the hypertensive hemorrhage. And then followed by the putamen, the other sites where there can be the intracerebral bleed, that can be within the basal ganglia, then followed by that in the deeper part of the cerebellum, right? Then followed by that pons. So these are the other sites where there can be the hypertensive hemorrhage, but the most common site for the hypertensive hemorrhage will be within the putamen, right? So this is about the various etiologies that will be causing the stroke. But you need to know, in case of the ischemic stroke, at what percentage of the blood flow there will be complete neuronal electrical failure, or there will be development of ischemia without infarction. So when the blood supply to the brain is less than 20 ml per 100 gram per minute, at this level of the blood supply, there will be cerebral ischemia, right? There will be cerebral ischemia without infarction, right? Cerebral ischemia without infarction. Okay, so that is what when the blood supply is less than 20 ml per 100 gram per minute. And when the blood supply is less than 16 to 18 ml per 100 gram per minute, at this point there will be complete neuronal electrical failure. Right, so there will be complete neuronal electrical failure. And at a level of blood supply to less than or equal to 10 ml per 100 gram per minute, at this point there will be cerebral infarction. Right, there will be cerebral infarction, where there will be death of the neuronal cells. So this is about the various etiologies that will be causing stroke, and that was the question related to the topic of stroke. Next question. A 21-year-old young lady presents with unilateral facial weakness. She is unable to close her eye on the affected side, and there are vesicles in her ear. She is suffering from 8th nerve palsy, 3rd nerve palsy, 5th and 7th nerve palsy. So the correct answer here is the 7th nerve palsy. So there is like unilateral facial weakness, and she is also not able to close her eye on the affected side. So this is the characteristic feature of the 7th nerve palsy. Now if you take the 7th nerve, that is the facial nerve palsy, What are the various causes of the facial nerve palsy? One of the very important etiology is the Bell's palsy, right? So in case of Bell's palsy, so what exactly is the cause of the Bell's palsy? It is idiopathic, we don't know, or it could be secondary to certain viral infection. And the other causes of the facial nerve palsy, that includes the herpes infection and then Ramsay-Hunt syndrome. What is this Ramsay-Hunt syndrome? It is the herpes zoster infection of the geniculate ganglia, right? Herpes zoster infection of the geniculate ganglia. So this is what is the Ramsay-Hunt syndrome. Then we have a other important etiology, that is acoustic neurocoma. Acoustic neuroma, it causes seventh nerve palsy, right? It will cause seventh nerve palsy, and that is by compression, right? So that is by local compression that will be causing, that is how the acoustic neuroma causes the seventh nerve palsy. And the other important etiologies are Rosenthal-Melkerson syndrome, right? RMS stands for Rosenthal-Melkerson syndrome. I'll be discussing about that. And the other etiologies that will be causing seventh nerve palsy will be sarcoidosis. So these are the etiologies that will be causing the seventh nerve palsy, right? Out of which, if you take the Bell's palsy, it is defined as an acute, right? It is defined as acute unilateral facial nerve palsy, right? Acute unilateral facial nerve paralysis. And the Bell's palsy, what is the age group at which you see this very commonly is around 20 to 40 years. That is the age group at which you see this Bell's palsy very commonly. And this Bell's palsy, it is very common in the pregnant women rather than men, right? And we have a terminology called as the Mobius syndrome. So Mobius syndrome is another important etiology that will be causing the seventh nerve palsy. And here in case of the Mobius syndrome, it is a rare neurological condition that primarily affects the muscles that control the facial expression and as well as the eye movement. So muscles which are controlling the facial expression and eye movement that are being affected in case of the Mobius syndrome. And there is weakness or paralysis of the facial muscles. So the facial muscles, they are like completely weak and they are like completely paralyzed. And Mobius syndrome, this is caused by absence or underdevelopment of 6th and 7th cranial nerve. So both 6th cranial nerve and as well as 7th cranial nerve underdevelopment will be there in case of the Mobius syndrome. Then what will be the features of the Bell's palsy? In case of the Bell's palsy, it is the lower motor neuron type of paralysis and it is usually unilateral. And in case of lower motor neuron type of paralysis, it is the entire half of the face that gets affected. So first, the individual is will have inability to wrinkle the eyebrows, right? The forehead will not be able to wrinkle and will not be able to close the eyes, unable to puff the cheek, right? And there will be deviation of the mouth to the opposite side, that is towards the normal side, because the paralyzed side will not have any movement, whereas the opposite side will have the movement. So in case of Bell's palsy, which is the lower motor neuron type of paralysis, it is the entire half of the face that will be completely paralyzed, right? Whereas in case of in case of lower motor neuron type of paralysis, it is ipsilateral half of the face will be completely paralyzed. Whereas in case of the upper motor neuron paralysis, right, it is contralateral lower half that will be paralyzed, right? Contralateral lower half that will be paralyzed, whereas contralateral upper half that will be normal, right? Contralateral upper half will be normal in case of the upper motor neuron type of paralysis. Contralateral lower half will be paralyzed in case of the UMN palsy. Now, and at the same time, right, you need to know the diagnosis of the facial nerve palsy or the Bell's palsy. See, the diagnosis, it is mainly clinical, right? The diagnosis is mainly clinical. I have shown you what all features will be there in case of Bell's palsy. And Bell's palsy, it is acute in onset. That is very, very important point. So Bell's palsy, the onset will be acute in onset. And in case of Bell's palsy, there will be feeling of stiffness of the face on the affected side. And these individuals, not only the motor, even there will be taste impairment, right? There will be taste impairment. And why is this taste impairment? That is because of the pathology within the caudate tympani nerve, which is a branch of the facial nerve. And not only the taste impairment because of the impairment of the caudate tympani, even there will be hyperacusis, right? Even there will be hyperacusis. And this hyperacusis, that is mainly because of weakness of the stapedius muscle. That is because of the weakness of the stapedius muscle, there will be hyperacusis. So these will be the features of the Bell's palsy. And the diagnosis, it is mainly by clinical feature and it is mainly by exclusion. And the other important test that can be done is the nerve excitability tests are done. The nerve excitability test will tell us, like, is there any facial nerve degeneration, or where exactly is the site of the facial nerve damage. That is, topo diagnosis can be made by the nerve excitability test. Then how do you treat these patients with the facial nerve palsy? So there is like pain, and for the pain, like, you need to give the analgesics, right? That is one important mainstay of treatment. And then you need to take care of the eye. So the cornea has to be protected, right? Because the individual is not able to close the eye in case of Bell's palsy. So the cornea has to be completely protected. Then physiotherapy or the massage of the facial muscles. So physiotherapy or the massage of the facial muscles, that is required in order to ensure that the strength of the facial muscles that gets improved. And the next important is prednisolone. So prednisolone, that should be given at a dosage of 1 milligram per kg for nearly around 10 days. Okay, prednisolone at a dosage of 1 milligram per kg for nearly around 10 days. And this prednisolone should be given within 72 hours. Right, the prednisolone should be given within 72 hours. And if there is suspicion of the viral infection, acyclovir addition is of questionable benefit. Okay, so this is about the treatment in case of the Bell's palsy. And what about the prognosis? Majority of them, right, 85 to 90% of them, they have good prognosis. The patients, they recover fully. It is only in 10 to 15% of the individuals where there is incomplete recovery. Where there is incomplete recovery, but 85 to 90% the recovery is good. Then what are the poor prognostic factors? The poor prognostic factors are advanced age, then hyperacusis is another important poor prognostic factor, and the presence of severe initial pain on the affected side, and the presence of complete facial palsy. So these are the poor prognostic factors. And good prognostic factors are preservation of the reflexes on the EMG, right? Preservation of reflexes on electromyography, and measurable blink reflex, right? Measurable blink reflex. So these are the good prognostic factors. Then you need to know about Mayerson-Rosenthal syndrome. This is also one of the important etiology that will be causing the facial nerve palsy. So in this, along with facial nerve paralysis, there will be swelling of the lips, right? There will be swelling of the lips, and there can be fissured tongue, right? There can be fissured tongue. So these are the features of the Mayerson-Rosenthal syndrome. And now there are certain etiologies that will be causing bilateral facial nerve palsies. What are the conditions where you have bilateral facial nerve palsy? That includes the Guillain-Barré syndrome, which will be like infranuclear causes for bilateral facial nerve palsy. Then next important etiology is leprosy. Then followed by that, sarcoidosis is another important etiology. Next, myasthenia gravis. So these are the causes for bilateral facial nerve palsy, and all of these are infranuclear causes. Then what are the supranuclear causes? Right? What are the supranuclear causes for bilateral facial nerve palsy? Supranuclear causes for bilateral facial nerve palsy, that includes the cerebrovascular accident and as well as the motor neuron disease. So this is in brief about the facial nerve. So this was the question on the Bell's palsy and as well as in details about the facial nerve. So yeah, so this is the image of Rosenthal-Melkerson syndrome, where there will be facial nerve paralysis, there will be swollen lips, and the presence of the fissured tongue. So these are the features of the Melkerson's-Rosenthal syndrome. Then followed by that, the next important question is on the parietal lobe. Lesion of dominant parietal lobe causes which of the following? Dysphagia, acalculia, dyslexia, contralateral neglect. Select the correct answer using the code given below. So in case of the parietal lobe involvement, there will be dysphagia, there will be difficulty in calculation, there will be difficulty in understanding the words, so dyslexia will be there. Contralateral neglect, that is not the feature of the parietal lobe involvement. So the correct answer is 1, 2 and as well as 3. So in the parietal lobe, what are the various broad main areas? The various broad main areas are, number 1, the primary sensory area, that is area number 3, 1 and 2. So this is the area within the parietal lobe. Now what is the function of this primary sensory cortex? The function is sensory signals from all modalities of sensation terminate in these areas. Right, sensory signals from all modalities right, so sensory signals from all modalities of the sensation terminate in this particular area. And what will be the clinical feature whenever there is damage to this primary sensory cortex? So there will be contralateral sensory loss, right? So there will be contralateral sensory loss. Okay, so exception is like pain and temperature sensation, right? So exception, pain and thermal sensation. There will be contralateral sensory loss because of damage to this primary sensory cortex that is within the parietal lobe. And the next important area is the sensory association area. So sensory association area, that is area number 5, 7 and 40. So this sensory association area, the function is, it is required for processing of the sensory inputs. Right, so this is required for the processing of the sensory input for perception, recognition of the general sensation. That is sensory association area. What will be the clinical feature whenever there is damage to this area number 5, 7 and 40? That will produce tactile agnosia. Right, tactile agnosia. So tactile agnosia is like, right, it is like astereognosis, where the individual will not be able to identify the object even by feeling that particular object with closed eyes. That is called tactile agnosia or astereognosis, right? And tactile aphasia. So even by perception of that particular object, the individual will not be able to feel that. That is tactile aphasia. Then the next important is the angular gyrus and supramarginal gyrus. So angular gyrus and the supramarginal gyrus, these are the sensory speech areas. They store visual images. Right, they store the visual images and recognize the object by light. And this area, it is associated with writing. This area, it is associated with naming of the fingers. And this area, it is required for calculation. Right, so that is angular gyrus and supramarginal gyrus. And whenever there is damage to this angular gyrus and supramarginal gyrus, the individual develops what is called as the 𝐒𝐻𝐻𝐿 syndrome. Right, the individual will develop 𝐒𝐻𝐻𝐿 syndrome. Okay, now what will be the features of the 𝐒𝐻𝐻𝐿 syndrome? So the features of the 𝐒𝐻𝐻𝐿 syndrome, that includes, number 1, sensory agraphia. right? Sensory agraphia. Number 2, will not be able to recognize the fingers. So finger agnosia, and will not be able to do the calculation. So acalculia, and then these patients will have right and left confusion. Right, these patients will have right and left confusion. So these are the features of the 𝗪𝐻𝐿 syndrome: sensory agraphia, finger agnosia, right and left confusion, and as well as the acalculia. So this is about the angular gyrus and the supramarginal gyrus. And you take this tactile agnosia. Yeah, tactile agnosia is characterized by lack of ability to recognize the objects through touch. That is called tactile agnosia. Then these individuals, like we have discussed, agraphia will be there. So agraphia, this is an acquired neurological disorder causing a loss in the ability to communicate through writing. Okay, so loss in the ability to communicate through writing, that is what is called as the agraphia. The other important areas in the parietal lobe will be the taste area. The function of the taste area is what? It is the taste receptive area. Right, it is a taste receptive area, and that is area number 43. Right, so this particular area number 43, that is required for conscious perception of the taste, and it is required for taste discrimination. Right, and it is required for the taste discrimination. And what will be the clinical features whenever there is damage to this taste area? That will result in ageusia, right, or hypogeusia. Right, ageusia or hypogeusia. And next important area in the parietal lobe is optic radiation. So optic radiation, this is a part of the visual pathway. Right, so this is a part of the visual pathway. And what will be the clinical features when there is involvement of the optic radiation? There will be homonymous hemianopia. Right, there will be homonymous hemianopia, and there is also defect in the optokinetic nystagmus. Right, so there is also defect in the optokinetic nystagmus. So this will be, and optokinetic nystagmus, it is a nystagmus that occurs in response to rotatory movement. That is what is called as the optokinetic nystagmus, and that gets affected. Okay, so this is about, so this optokinetic nystagmus, it is present normally, but this get affected whenever there is damage to the optic radiation, which is a part of the parietal lobe. So in summary, whenever there is damage to the parietal lobe, you have primary sensory cortex, so contralateral sensory loss will be there, and multimodal association area, that is sensory association area, area number 5740. So the lesion in this area will cause the tactile agnosia, astereognosis or tactile aphasia, and damage to the angular gyrus and supramarginal gyrus will cause the 𝗪𝐻𝐿 syndrome, and damage to the taste area will cause the ageusia or hypogeusia, and damage to the optic radiation will cause the homonymous hemianopia or defect in optokinetic nystagmus. So these are the principal areas of the parietal lobe, and whenever their lesion occurs, what will be the signs and as well as the symptoms. So this is about the question on the parietal lobe. So the next question is on the topic of the neurocutaneous markers, that is neurofibromatosis. Which of the following are the clinical features of the neurofibromatosis type 1? Angiomas, axillary freckles, cutaneous schwannomas, neurofibromas. So select the correct answer using the code given below. The options here are angiomas, they are the features of neurofibromatosis type 1. Axillary freckles, they are also the features of neurofibromatosis type 1. Cutaneous schwannomas, they are not the features of neurofibromatosis type 1. And the presence of neurofibromas, these are also the features of the neurofibromatosis type 1. So the correct answer is 1, 2 and as well as 4. So if you see the examples of the neurocutaneous syndromes, there are 5 important common neurocutaneous syndromes. And what is another name for this neurocutaneous syndromes? Also called as phacomatosis, right, also called as phacomatosis. And this phacomatosis, 5 we have common conditions which will be causing the neurocutaneous syndromes or phacomatosis, and then there are some less common conditions. So first, let me tell you what are the common causes for the neurocutaneous syndromes. So the common causes include neurofibromatosis type 1, which is also called as von Recklinghausen's disease, and the second one is the neurofibromatosis type 2. And the other common causes apart from neurofibromatosis, that includes tuberous sclerosis, right, and the complex form of the tuberous sclerosis. Then third one is ataxia telangiectasia, and fourth common condition include Sturge-Weber syndrome, then the other common condition include von Hippel-Lindau disease. So these 5 are the common neurocutaneous syndromes, and we have some less common conditions that include incontinentia pigmenti, basal cell nevus syndrome, Bonnet-Duchesne-Blanc syndrome, then neurocutaneous melanosis, progressive hemifacial atrophy, Cowden disease, then lipomatosis, then epidermal nevus syndrome. So these are less common conditions. So out of which, let me discuss about this neurofibromatosis type 1. And if you take the inheritance of all these types of the neurocutaneous syndromes, neurofibromatosis type 1, it is autosomal dominant type of inheritance. Tuberous sclerosis is also autosomal dominant type of inheritance. Sturge-Weber, it is like sporadic in nature. Ataxia telangiectasia, it is autosomal recessive type of inheritance. And linear nevus syndrome, so it is the sporadic in inheritance. So the skin manifestations are very important because here it is neurocutaneous syndrome. And in neurofibromatosis type 1, it is the CAFU spots. So CAFU spots, these are the very important neurocutaneous or cutaneous markers in case of neurofibromatosis type 1. And then neurofibromas are another important feature. And next you have axillary or the inguinal freckling, right, axillary or inguinal freckling. And in tuberous sclerosis, which is also autosomal dominant type of inheritance, adenoma sebaceum is one important cutaneous manifestation. Then the presence of the ash leaf spots is another important cutaneous manifestation. Third is the presence of Sjogren patches, then the presence of fibrous plaques, and as well as periungual fibroma, right, periungual fibroma. So these are the cutaneous manifestations in tuberous sclerosis. And in Sturge-Weber syndrome, it is the facial angioma, which we give by the name the port wine stain. That is a characteristic feature in case of the Sturge-Weber syndrome. And that will be usually over the face. And in ataxia telangiectasia, it is telangiectasias, and these telangiectasias, they are distributed over the eyes, distributed over the eyelids, then ears and popliteal fossa. So these are the places where you have the presence of ataxia telangiectasia. And then linear nevus syndrome, which is like sporadic, and here it is the presence of sebaceous nevus, right, the presence of the sebaceous nevus, and then verrucous nevus, right, verrucous nevus, and then acanthosis nigricans, right, acanthosis nigricans. So these are the skin manifestations in linear nevus syndrome. Now out of which, let me discuss about the question in detail, that is neurofibromatosis type 1 and type 2. So neurofibromatosis type 1 and type 2, like the neurofibromatosis type 1, this will be, right, this will be peripheral neurofibromatosis, right? And this is called von Recklinghausen syndrome. Whereas neurofibromatosis type 2, that will be central neurofibromatosis. And this central neurofibromatosis, here you have very important manifestation, that is bilateral acoustic neurofibromatosis. That is neurofibromatosis type 2. But between these two, which is more prevalent, neurofibromatosis type 1, this is most prevalent. 90% it is neurofibromatosis type 1. And 10% is neurofibromatosis type 2, that is less prevalent. And in neurofibromatosis type 1, the defect is in the gene neurofibromatosis type 1 gene, and the abnormality is on the chromosome number 17. Whereas neurofibromatosis type 2, the gene that is being defective is the neurofibromatosis type 2 gene, and the chromosome that is being defective is the chromosome number 22. And both of them, they are inherited as autosomal dominant type of the inheritance. So this neurofibromatosis type 1, you have a diagnostic criteria, and the entire diagnostic criteria, right, let me just teach you in the form of a mnemonic, in which like you have what is called cave spots. So you have the very important cutaneous manifestation here, that is the presence of the CAFU spots. Then freckles. So there will be axillary or the inguinal freckling, and the word F is fibroma. And the eye manifestations, that will be in the form of Lish nodules, right? And S will be skeletal manifestations, and that skeletal manifestations will be in the form of bowing of the legs, right? And P is positive family history, right? P is positive family history, right? And OT is the optic tumor, and this optic tumor, it is glioma, right? It is glioma. So these are the diagnostic criteria in case of neurofibromatosis type 1. And in this, again, you need to be aware that the number of CAFU spots, so more than or equal to 6 CAFU macules should be there, and they should be of size 5 millimeters in diameter, right? They should be of size 5 millimeters in diameter in prepubertal individuals, whereas these CAFU macules, they should be of 15 millimeters in diameter in post-pubertal individuals. So 6 or more CAFU macules, 5 millimeters in prepubertal and 15 millimeters in post-pubertal individuals. Next is the axillary or inguinal freckling, and the next one is the Irish Lish nodules. And this Irish Lish nodules, it should be like more than or equal to 2 Irish Lish nodules, right? And the neurofibromas, or one plexiform neurofibroma, and this neurofibromas, they should be more than or equal to 2 neurofibromas or one plexiform neurofibroma, and a distinctive osseous lesion. And what is the distinctive osseous lesion? That will be in the form of sphenoid dysplasia, right? So this will be in the form of sphenoid dysplasia or cortical thinning of the long bone, right? Cortical thinning of the long bone. So this will be the distinctive osseous lesion. Next, optic gliomas, and then the first degree relative with neurofibromatosis type 1. So that is like positive family history. So these are like the diagnostic criteria for neurofibromatosis type 1. And the most common orthopedic manifestation, right? The most common orthopedic manifestation of neurofibromatosis type 1, that is scoliosis. Although it is not specific enough to be included as a diagnostic criteria, but this is one of the most common orthopedic manifestation in the neurofibromatosis type 1. And next, this is the CAFU spots. So how many CAFU spots should be there? So there should be minimum of 6 CAFU spots, and they should be of size 5 millimeters in diameter in prepubertal and 15 millimeters in diameter in postpubertal. And these CAFU spots, they are like flat pigmented birthmarks. And the next important is the axillary freckling. Right, the next important is axillary freckling. So the presence of the axillary freckles, that will be like of circular spots on the skin, and they are darker, and they are due to what? They are due to deposition of melanin. So this is what is called the axillary freckling. And the next important is, see, these are neurofibromas. So these are basically benign nerve sheath tumor in the peripheral nervous system. And this is what is the example of the leash nodules. They are present within the iris. And these leash nodules, they are melanocytic hamartomas, right? They are melanocytic hamartomas that appear as well-defined dome-shaped elevations, right? Well-defined dome-shaped elevations. So these are the leash nodules. And this is like one of the important orthopedic manifestation, that is sphenoid dysplasia. That is also the one of the diagnostic criteria in the neurofibromatosis type 1. And the next important is presence of glioma, that is optic glioma, that is the optic nerve tumor, which is also the part of the diagnosis in case of neurofibromatosis type 1. And this optic gliomas, they are present in approximately 15% of patients with neurofibromatosis type 1. And the presence of this optic glioma is included as one of the criteria in establishing the diagnosis of neurofibromatosis type 1. Okay, so these are the diagnostic criteria in case of neurofibromatosis type 1. And if you see particularly CNS neoplasms in case of neurofibromatosis type 1, that includes number 1 optic glioma, and number 2 meningioma, and next is neurofibromas, then followed by that schwannomas, next astrocytomas, and followed by that neurolemomas. So these are the CNS neoplasms in case of neurofibromatosis type 1. And what are the other tumors that can be there in neurofibromatosis type 1 is, there can be like pheochromocytoma, then rhabdomyosarcoma, leukemia, then there can be also the presence of the Wilms tumor, and then juvenile xanthogranulomas. So these are the features of, these are the neoplasms in neurofibromatosis type 1. Whereas you take in case of neurofibromatosis type 2, the diagnostic criteria for the neurofibromatosis type 2 is that there should be 8th nerve mass. Okay, so bilateral 8th nerve mass consistent with acoustic neuromass, right? And this bilateral 8th nerve mass consistent with acoustic neuromass, that is demonstrated by CT or the MRI, right? That is demonstrated by the CT or MRI, right? And a parent, sibling or child with neurofibromatosis type 2. So there should be family history of neurofibromatosis type 2. So this will be like diagnostic criteria for neurofibromatosis type 2, right? So either there should be like bilateral 8th nerve mass which is consistent with acoustic neuroma as demonstrated by CT scanning or MRI, right? Or if it is not bilateral, right, it should be at least unilateral 8th nerve mass, right? Unilateral 8th nerve mass, or any two of the following, right? Any two of the following. What are these any two of the following? That includes neurofibromas, that includes meningiomas, or presence of the glioma, presence of the schwannoma, presence of juvenile posterior subcapsular opacity. right? Juvenile posterior subcapsular opacity. So unilateral eighth nerve mass, along with this, any of these two tumors should be there, right? Any of these two tumors should be there. Okay, so this will be the diagnostic criteria for neurofibromatosis type 2. And in case of neurofibromatosis type 2, the rule of 2 is that, so first and foremost, it is neurofibromatosis type 2, and the gene that is being defective is present on chromosome number 22, and there should be, or there will be, bilateral vestibular schwannomas, and they are present in around second to fourth decade, and the initial prevalence is estimated to be around 1 in 2 lakh population, right? 1 in 2 lakh population. So this is what is the rule of 2s in case of the neurofibromatosis type 2. So it should be bilateral acoustic neuromas or bilateral schwannomas. So this is about the question related to the neurocutaneous syndromes or the neurofibromatosis type 1, right? So the next question is on the topic of the Parkinsonism. Which of the following are the clinical features of the Parkinson's disease? Bradykinesia, rigidity, spastic gait, mask-like face. Select the correct answer using the code given below. Bradykinesia will be there, then rigidity will be there, and mask-like face is there in Parkinsonism, but not the spastic gait. So the correct answer is 1, 2, and as well as 4. So if you see the differential diagnosis of the Parkinsonism, so one is your Parkinson's disease, right? One is the Parkinson's disease. So this is like either sporadic, right, or the genetic, right? Sporadic or genetic. Then atypical Parkinsonism, that includes multiple system atrophy, which is of cerebellar type or Parkinsonism type. So that is MSA-C or MSA-P. C is like cerebellar type, P is like Parkinson type. And next one is progressive supranuclear palsy, then corticobasal degeneration or corticobasal syndrome, then frontotemporal dementia. So these are the types in case of atypical Parkinsonism. Secondary Parkinsonism, most common, it is like drug induced. Then these drugs, they are mainly the antipsychotic drugs, then tumors, then infections, then there are vascular causes for Parkinsonism, normal pressure hydrocephalus, then trauma, and then liver cell failure. So these are the causes for secondary Parkinsonism. Then we have neurodegenerative disorders that is associated with Parkinsonism, and these neurodegenerative disorders, they include Wilson's disease, then Huntington's disease or the Huntington's chorea, then spinocerebellar ataxia, mainly type 3. So these are the neurodegenerative disorders that are associated with the Parkinsonism. Okay, so these are like various differential diagnoses of Parkinsonism, and let me discuss in detail about this Parkinsonism. So Parkinsonism, it is the second most common neurodegenerative disorder. And what is the first most common? The first most common is the Alzheimer's. And this Parkinson's, the most common cause of Parkinsonism, that is the Parkinson's disease. So the Parkinson's disease, right, the Parkinson's disease, it is under the primary cause for Parkinsonism, and this is caused due to genetic or sporadic reasons, and the defect is on chromosome number 4. And what is the gene that is being mutated? It is the PARC gene that is being mutated, right? And this particular PARC gene, it is also known as SNCA gene, which is alpha-synuclein gene, which is present on chromosome number 4. And you take secondary causes. The most common cause for secondary cause for Parkinsonism will be drugs. And these drugs, they include like haloperidol, chlorpromazine, and then metoclopramide. Then what are the other secondary causes for Parkinsonism? Post-encephalitic Parkinsonism. Then we have toxins. what are these toxins? That includes the MPTP, that is methylphenyl tetrahydropyridine. And then the other toxins, they include manganese and then carbon monoxide. These are the secondary causes for Parkinsonism. And vascular causes I have discussed. Tumors, mainly the tumors within the basal ganglia can cause secondary Parkinsonism. And then punch drunk syndrome, right? Punch drunk syndrome, that is observed in boxers, and infections like HIV and as well as the influenza. And in case of Parkinsonism, like first you have the non-motor manifestations. These are the earliest. Okay, so non-motor manifestations, these are the earliest manifestations. And what are these non-motor manifestations which are earliest? That includes loss of sensation of smell, that is anosmia, and there can be also constipation, then followed by that mood and sleep disorders. Mood and sleep disorders. And the motor manifestation, the earliest manifestation is the development of the resting tremors, and these resting tremors will be usually of the frequency 4 to 6 hertz. And these resting tremors are usually asymmetric in nature. They are of pill rolling in nature, pill rolling tremors, right? And this resting tremors, they worsen with anxiety. They worsen with anxiety and they disappear with sleep, right? Next, like typical and the atypical Parkinsonism. So the typical Parkinsonism is that where there will be a good response to levodopa, that is typical Parkinsonism. Then the poor response or atypical Parkinsonism is like where there is poor response to levodopa. And what are the other features apart from the tremors? The other features, they include like bradykinesia, where there will be slowness of movement, and next important is rigidity. And even this rigidity also, the upper limbs you have cogwheel rigidity, lower limbs you have the lead pipe rigidity. And these patients, they have autonomic disturbances, and that will be responsible for the postural instability. So these patients, they will not be able to stand, they'll have the fall. Okay, so the gait also, if you see here, it is the short shuffling gait, and this gait we describe it as like the festinate gait. The gait is the festinate gait. And what happens to the deep tendon reflexes? The deep tendon reflexes, they are like normal, they are not altered, and the plantar reflex will be the flexor response. And the very important inclusion body that you have is the Levi body, right? The inclusion bodies will be the Levi body. And what is the treatment? The first line treatment will be levodopa, and this levodopa, it should be combined with the carbidopa. Okay, and for tremors you need to give the anticholinergic drugs. So this will be the treatment in case of the levodopa. So some of the most frequently asked questions in Parkinsonism, the tremors, they are like resting tremors. Rigidity, it is cogwheel rigidity in upper limbs and lead pipe rigidity in the lower limbs. And the postural reflexes, they are not preserved because of the autonomic instability. And at one point of time, they are like completely confined to wheelchair. So once they are completely confined to wheelchair, that is called wheelchair sign of Quinn. Then gait is like festinate gait, where there will be slow shuffling steps with stupid posture. Bradykinesia, where the movement is slow and as well as delayed. That is because of the decrease in dopamine levels and increase in acetylcholine levels. Micrographia, the handwriting will be very small. Mask-like faces, and this we call it as the expressionless faces. And the deep tendon reflexes, they are unaltered, and the plantar reflex, it will be a flexor response. So these are some of the most frequently asked questions on the Parkinsonism. And this is the inclusion body, right? And this inclusion body, it is Levi body, like which is stained brown. Okay, and it is present within the brain cell of the substantia nigra in case of the Parkinson's disease. And this brown color, right, it is due to positive immunohistochemistry staining for alpha synuclein. right, for 𝐶𝐶-nuclein. Okay, so this is about the inclusion body, that is Lewy body. So the drug of choice or the first line treatment will be the levodopa, and levodopa can undergo peripheral decarboxylation. To prevent that, you need to give dopa decarboxylase inhibitor, that is carbidopa. And within the brain, once there is peripheral decarboxylation, dopamine is released, and we have many dopamine agonists also that can be given. That includes apomorphine, rotigotine, bromocriptine, cabergoline, pergolide, pramipexole, ropinirole, or amantadine. And this dopamine within the brain, it can undergo metabolism by two important enzymes, that is monoamino oxidase and as well as the catechol O methyl transferase. So the monoamino oxidase inhibitors are rasagiline and salicylic, and catechol O methyl transferase, that includes entacapone and as well as tolcapone. By giving these drugs, dopamine will not be metabolized and the levels of the dopamine will be elevated within the brain, and the features of Parkinsonism will come down. Anticholinergic drugs, they are mainly given for reducing the tremors, and the examples include piperidine, benztropine, orphanidine, procyclidine, and trihexyphenidyl. So these are the various molecules which are available for the treatment of the Parkinsonism. So this completes the discussion of this very important question, that is on Parkinsonism. Next question. Which of the following are the tricyclic antidepressants? Amitriptyline, dosulipin, paroxetine, then imipramine. So select the correct answer using the code given below. So amitriptyline, dosulipin, and as well as the imipramine. These three are the tricyclic antidepressants. Whereas, so the answer is what? That is 1, 2, and 4. Then what is paroxetine? Paroxetine, it is a class of medications belonging to selective serotonin reuptake inhibitors, right? And it is also the one which is used for the treatment of the depression and as well as the other mental illnesses, right, as well as the other mental illnesses. And how is that it will treat depression and other mental illnesses is this paroxetine will increase the levels of serotonin within the brain. Okay, it will increase the levels of serotonin within the brain. So paroxetine, it is not a tricyclic antidepressant, it is a selective serotonin reuptake inhibitor. Whereas amitriptyline, dosulipin, and as well as the imipramine, all these are the tricyclic antidepressants, right?